due to the region of the body that we're talking about, and the region of the body that we're discussing. I will attempt to use gender neutral language throughout my presentation, except for when referring to specific anatomical regions. In that case, I will talk about male and female, and what I mean by that is male assigned at birth and female assigned at birth. Transgender pelvic care and transgender anatomy is a whole different ballgame, and one that we're just not diving into today, but wanted to recognize that. So, who has a pelvic floor? What does? Male, female, and brute. Okay. So, what is the pelvic floor? Pelvic floor is a set of muscles and ligaments and structures, I say between the legs, at the base of your trunk. And I have a model here that we can pass around. So this is your hip bones here, and then between your two sit bones. So I say if you sit on a bleacher too long and your butt bones get sore, that's these two bones right here. And all the muscles in between are going to be your pelvic floor muscles. Okay, our pelvic floor muscles support the organs like the bladder, our intestines, our diaphragm, all of that good stuff. It provides stability for the pelvis and trunk, has a role in sexual functioning, okay, and for, females, having babies, carrying babies, birthing, helps us pee and poop, supports our postural muscles, and coordinates our breathing with the diaphragm. Now, these muscles can be underactive, overactive, non-functioning, just like any other muscles in the body. I will let, if anyone wants to see it, it does kind of pull apart easily, so don't be afraid if you feel like you broke it. It goes back together easily. So I like this diagram because it really demonstrates how many different muscles there are in the pelvic floor. Each color is a different muscle. There's 3 different layers to it. And generally we think of them as superficial muscles and deep muscles. All of them have their own function, although when we think of a pelvic floor contraction, they kind of all go together in a way. But you can see there's just slight differences between the male anatomy and the female anatomy. The muscles are just structured a little bit differently, but they're very, very similar. Last photo of anatomy. I really like this one because it kind of puts everything together. So this is kind of a picture of someone just standing, and you can see with the pelvic floor muscles, we actually have a few of them that start on the inside of the pelvic floor that go out and actually insert and attach to your hip muscles. So the pelvic floor and your hips are very correlated and intertwined together. And so that's what we're talking about when we talk about trunk and pelvic stability and how these muscles all work together to make you feel nice and solid or not. Which is what we'll talk about today. Just like any muscle in the body, you can develop tension and trigger points, muscle strains, and injury to these muscles. And so that's kind of where pelvic health comes in, is we have to treat these muscles very similarly to other muscles, but it's also very different because of where they are in the body. That's right. So, common pelvic floor issues, urinary problems. This is leakage, even if it's just a couple drops, okay? Overactive bladder, so peeing when you don't want to, or you're trying to get to the bathroom and it comes out before you can get there. Increased frequency, if you're going every single hour. Nocturia. Nocturia is if you get up at night to go to the bathroom. If you are under 65, you should not get up at all. If you're over 65, once is acceptable. And then urinary retention. So if you try to go to the bathroom and nothing's coming out. Other pelvic floor issues can be bowel problems. Most commonly, this is going to be constipation or diarrhea, or going along with diarrhea, fecal incontinence or stool leakage. Pelvic pain. You can have pelvic pain in the low back, in the hips. It can be inside, deep, It can be outside, more superficial. You can also get pelvic pain from infections or other diseases that are going on. And then prolapse. Prolapse is a very common condition. Many females experience prolapse. Males can also experience prolapse, which is not commonly thought of, but it can happen as well. So what is normal for peeing? If you go about 5 to 8 times a day, a little more, a little less is okay. Everyone's a little different. Like I said, if you're under 65, you don't pee at night, or you don't get up to pee at night, unless maybe you drink a ton of water right before you went to bed. If you're over 65, you get up about once a night. Normal for peeing is if you can hold it if you need to. Say you should feel confident holding it for at least 30 minutes to an hour. You don't worry about having infections, okay? If you're someone who says, oh, I get a UTI every month, that is something we would want to address. You don't worry about your bladder, or you're not constantly thinking, where's my next bathroom location, okay? If you are someone who's like, where am I gonna go? Where am I gonna go? That is something we would wanna work on. And then you pee for at least 7 to 8 seconds per pee, usually. So anything outside of these norms can be considered a pelvic floor dysfunction. So let's dive into urinary incontinence a little bit. There are many kinds of urinary incontinence. And when I say incontinence, I mean leakage, okay? Pee coming out when you don't want it to. Urge incontinence is when you say, I've got to go now. And you are trying to get to the bathroom as fast as you can. You're trying to pull your pants down. And the leakage comes without you wanting it to. Stress incontinence is when our body is undergoing any sort of physical stressor, okay? Coughing, sneezing, jumping, you're trying to jump on the trampoline with the kids, or, you're trying to wrestle with the kids and you accidentally leak, or you're laughing, if you ever just can't stop laughing and you pee your pants, that is stress incontinence. Functional incontinence is going to be, there is some other reason you can't get to the bathroom. So easy examples of this would be you fall and broke your leg and you can't walk to the bathroom and you can't get there because you can't walk. So a mobility reason. Another big functional incontinence piece is those who have cognitive impairments, so dementia, Alzheimer's. They're having a processing problem with figuring out they need to go to the bathroom or not being able to get there in time. And then mixed incontinence is an overarching term we use to describe if you have 2 or more types of incontinence, okay? So this is my first friendly activity of the day. Oops, okay. So if you hold up a fist, squeeze it as hard as you can, I want you to hold that for the next 8 hours. Would your hand be sore? Yeah. If you're holding your fist like this, can you pick up a pen and write? No, right? So a lot of times we think if we have a pelvic floor dysfunction, we're like, oh, I've got to do Kegels. I've got to get stronger. Yes, but for some people, strengthening isn't necessarily the issue. It can be that your pelvic floor is too overactive and too contracted, tight, lots of things like that, okay? So if your pelvic floor is holding like this all day and you're holding tension, you're not going to be able to contract and hold in your pee when you want to. So if you are someone who is holding your tension in your pelvic floor like this, your first order of business is going to be relax, lengthen, and open and stretch. Then we can start to work on strengthening. But if you're someone who's like this all day long, doing Kegels and contracting over and over is not going to do much for you. And it can actually make the problem worse. And so that's why it's really important for us to figure out what's the root cause of what's going on here. Is it a lengthening problem or is it a strengthening problem? And it's confusing because sometimes it's both. Other things that we can do for urinary leakage and urinary dysfunction is bladder retraining. Okay, so reteaching our bladder how to coordinate when we want to hold it and when we want to go to the bathroom. Sometimes the brain and the bladder can get in a little bit of an argument about who's in charge. We can also do dietary modifications. So figuring out, are you having bladder irritants? Okay. Coffee, sparkling waters, alcohol, tea, caffeine, anything that tastes good in the world is going to irritate your bladder. Okay. Increasing your fluid intake. We think that if I'm going to the bathroom too much and I'm leaking, oh, I should drink less water. No, drink more water. It's very confusing, but if you're dehydrated, that can make leakage worse too. So I'm going to teach you how to do a pelvic floor contraction now. And don't worry, if you are someone who's holding tightness, doing a couple of these won't be the end of the world. I'm just saying don't do them all day, every day, necessarily. So the next is a trick we use to help people overcome incontinence when you are coughing, sneezing, laughing. So if you're one of those people, okay, I want you to imagine, for my female-bodied persons out there, I want you to imagine you are picking up a blueberry with your vagina. Okay? If you are a male-bodied person out there, I want you to pull in or contract your penis. That is how you do a pelvic floor contraction. Now, keep in mind, you should not be holding your breath while you do this. If you pull in and you find yourself tensing and holding your breath, we have to isolate and be a little bit more gentle in that contraction, okay? So getting to the actual knack of it is, I want you to gently pick up the blueberry and give yourself a cough. That is a nice trick you can use to prevent leakage with coughing, sneezing. Now, don't get me wrong, if you are in the middle of flu season and you are just hacking up a lung and coughing and coughing and coughing, this is going to take a little bit more work, but that'll hopefully get you started. Urge suppression, okay? So urge suppression is a bladder retraining technique we use for those of you who have leakage when you're on your way to the bathroom, okay? So maybe you don't make it in time. Maybe you are trying to pull your pants down and get them unbuttoned and your button snags and you're just like, I can't get it. Sometimes people have urge incontinence when they hear or see or feel running water. Sometimes it happens when people are pulling into the driveway or they're trying to unlock their front door. Okay, so the way you get around that is called urge suppression. So we freeze. First thing we do is stop what we're doing. You stop trying to unlock the door. You stop trying to unbutton your pants. Focus on your pelvic floor. Squeeze. Then you would do a couple of the pelvic floor contractions like we just practiced, the blueberry. Pick up the blueberry a couple times. Contracting the pelvic floor inhibits the bladder from releasing. Breathe. Okay? So much of the time you're holding your breath, trying to get there. When you hold your breath, it increases the pressure in your abdomen, putting pressure on the pelvic floor, making the problem worse. So breathe. And then I say ease/evaluate. Do I really need to go? Was this just my bladder trying to dictate what's going to go on here? If you do need to go, walk calmly and slowly to the bathroom. This is probably the hardest part of the whole sequence, okay? And I would say repeat the sequence as necessary. Okay, so you might need to do this a couple times through. This is not like you do it one time and you're fixed for life. This is something that takes a lot of practice to get control. Okay. Let's move away from urinary problems and talk about bowel problems. Okay, so our two main bowel problems that people have are constipation and leakage. And leakage most commonly comes along in the form of diarrhea, but not always. So I always have, when I have new clients, I always have them let me know where they are on the Bristol stool form scale, okay? So if you are in the type 1 or 2 region, okay, if you have separate hard lumps, they're hard to pass, we would consider that as constipation. If you're down here and it's really loose, watery, really lacks any substance or solid, you're going to be down more in the diarrhea range. Okay. Most commonly, people have leakage if they're in this type 6, 7. Okay. And generally, it's thought of if you're going through a GI bug and you're down at type 7 all of a sudden, pretty much no one can control that. It's really hard. Okay. I say it's like if I turn the garden hose on and I told you to hold the garden hose shut with your hand, would you be able to stop the water from coming out? No. So one of our first things is going to be kind of pulling you away from either end of the scale. You can also have leakage if you are one of the more normal types of stool as well. So one of the things we have to figure out is what kind of stool is it, and then we got to examine the problem a little bit more, because they are very separate problems in and of themselves, but they are more common based on what type of stool you have. Is that making sense? Mm-hmm. I know, it's confusing, even to me. So one of our best things we can do for normalizing our stool, okay, if you're either 1 or 2 or you're 6 or 7, fiber. Fiber consists of soluble fibers and insoluble fibers. Our body needs both, okay? Best thing you can do is to incorporate whole grains, fruits and veggies, real foods into your diet. And I say if you are struggling to incorporate real foods with fiber into your diet, then supplements can be helpful, but it's not usually like the best thing to do right away. It's can we incorporate this in a healthy way first? Fiber is super, super critical because it helps our really hard stools become soft and easier to pass. And it also helps our really liquidy, watery stools become more hard and formed. So it's actually kind of like a magic tool that brings everyone to the middle. Now, the key with fiber is that the bowels are really, really, really slow at learning. If you just suddenly start taking a double dose of Benefiber or Miralax, it's probably going to be a nightmare, okay? It has to be a very slow, gradual addition to the diet, and not all fibers are created equal. Some people are going to respond better to one, some people will respond better to another, okay? I say the best thing you can do is get it within your regular diet, real foods. And then again, if we have to go with a supplement route, it's a very slow addition. And we're not buying like 5 pounds at once. We're starting with a very small amount to see if that one's going to work for our bodies. Okay? This can be a very tricky thing to navigate. And it can feel a little bit like trial and error. So there's not like a one fits all answer, and it's difficult to manage. I will admit that. The other thing we can do for mainly constipation, but honestly everyone, is work on our toilet positioning, okay? So best practice, I guess, for toilet positioning is going to be sitting on the toilet. Your knees are slightly higher than your hips, okay? Your feet are planted firmly on the floor, and if needed, a stool to help bring those knees up higher. Okay, we have a belly big mentality. I'm not bearing down and holding my breath, but I'm either breathing through a straw or going shh. Okay, so if everyone puts their hands on their belly and go shh. Can you feel your belly gently push out? Okay. That is a healthy way to have a bowel movement rather than holding your breath and pushing with all your might, okay? You should have all grabbed one of the handouts on bowel positioning to help give you a reminder at home. If you're looking for a stool, you might have seen one of these before. It's called a squatty potty, okay? So it's a nice little rounded stool that goes around your toilet. And then you could just pull it out, prop your feet up, and then slide it back under when you're done. That can be very helpful, especially if you're someone who needs a higher toilet seat, because it's easier to get off of, or you have a hip problem or a back problem that requires you to have a higher toilet seat to be able to have more ease with getting off of it. Pelvic pain, okay? I was telling Kelsey I was trying to summarize pelvic pain into one slide and I found it very difficult. There are so many kinds of pelvic pain, and it can be really hard to pin down what's the problem here. So it can be a gynecological problem, okay? So that indicates an organ disease or an organ disorder. So that could be like endometriosis. You could have like uterine fibroids, uterine cysts, things like that. Gastrointestinal, okay? So a lot of times that's pain from constipation. If you have irritable bowel syndrome, inflammatory bowel disease, Crohn's disease, other types of stomach problems. Okay, neurological, so that can be nerve damage or nerve irritation. There's a nerve in the pelvis called the pudendal nerve that is notorious for getting irritated. Really common in bikers who sit on a bike seat a lot. Can be urological, so you can have pain from the bladder. Okay, interstitial cystitis is a common problem that comes from the bladder. It could also just be recurrent UTIs or recurrent bladder infections can be painful for people. Musculoskeletal, so that's going to be problems with the pelvic floor muscles themselves, bones, ligaments, those other structures, okay? That could be pain with sex. That could be pain with sitting. You could have pain on your tailbone from a fall. So those are going to be all like musculoskeletal problems. And then you can also have referred pain. You might have pain in your pelvis, but it might actually be coming from your back or your hips. So it's good to take a full broad look at what's going on to figure out, okay, where is your pain coming from? Why are you getting it? So we can address it the best way. Prolapse. Okay, I think this is our last topic. So types of pelvic organ prolapse. You can have a cystocele, so that is a bladder prolapse. So as you can see here, the bladder on the side here is when it comes down and it's going towards the exit of the vaginal wall. You can have a uterine prolapse. So that's when the uterus is sliding down towards the exit. Then you can have a rectocele where the rectum is coming down. You can also have an anal prolapse. So that's where like the anal mucosal lining is prolapsing out. Now you can have multiple types of prolapse here. So some people have cystocele and rectocele. You can have multiple types. One of the biggest contributors to prolapse is women who have babies. You know, that is because the baby sits on top and really just helps push everything down. But like I said, males can also have prolapse. And that's why, you know, one of the biggest things is modifying if you're having constipation. Okay, constipation can cause you to strain, put pressure down on that pelvic floor, and it can exacerbate these problems. Stages of prolapse. So not only are there multiple types of prolapse, each one can have a different stage. And there's two different diagrams here to just kind of give you an idea of how this is working. So this one really shows the different stages right next to each other. And this is how we assess and kind of diagnose what type and grade of prolapse that you're having based on when we would do an internal assessment. So 0 is nothing, no prolapse. Stage 1 is you see those tissues coming down slightly. Stage 2 is going to be those tissues are coming down to the level of exit on the pelvic floor. We call it the introitus, is where the opening of the vaginal canal is. Grade 3 is those tissues are actually coming outside of the body. Okay, sometimes they go back in on their own. Sometimes you need to manually put them back in or splint to keep them from coming out. Okay, and then grade 4 or stage 4 is when those tissues have come all the way outside of the pelvis and they're not going back in. That one is very obvious and generally needs fixation by surgery. So our goal is to prevent it from getting to a stage 4. Now, generally it's thought of with physical therapy, we can help reverse prolapse by about 1 stage. And sometimes you can actually have prolapse without having any symptoms of prolapse. So sometimes people have even a stage 1, even a stage 2 prolapse and not even realize it. The most common symptom of prolapse is that sense of heaviness or pressure in the pelvis. Other symptoms that you can have that are actually caused by a prolapse are urinary symptoms. So if you have that increased urgency, increased frequency, incontinence, bowel symptoms, bowel incontinence, incomplete emptying. You feel like you tried to go to the bathroom and you got a little out and like you feel like there's still more in there, but nothing's coming out. If you're straining, if you need to splint or manually keep tissues up to go to the bathroom. And then if you have back pain, pelvic pressure, or like pelvic discomfort in the standing position or positions where you're going against gravity. So even though you don't have this sense of pelvic heaviness, but you have some of these other symptoms, sometimes that is an indication of prolapse that could be assessed and diagnosed. Breathing mechanics. All right, we can do this one. So breathing mechanics, how do we breathe, you know, throughout our movements on a day-to-day basis? So what I want you to try to do is first, if you are able, stand up, holding your breath. This is where I make you all get up because I'm a therapist. You know, take a deep breath, hold your breath, sit down. Okay. Now the next time you do this, I want you to take a deep breath in. As you stand up, breathe out through a straw. And tell me if it's easier or more difficult. What do we think? Easier. Love it. Okay. So you should feel a difference in that you can sit down. You should feel a difference in the pressure management between those two. One of them, we're using our pressures well. One of them, we're not. Okay. The pelvic floor works in synergy with the abdominal muscles during an exhalation to manage those pressures. Okay. If we're constantly holding our breath during movements, it can put a lot of stress and strain on the pelvic floor. So if you are lifting something super, super heavy, yes, you're going to hold your breath every once in a while. But it's if you're holding your breath every time you stand up, every time you bend over to lift something up, every time you do X, Y, Z. If you're holding your breath so frequently, that can start contributing to pelvic floor muscle dysfunction. So we've talked a lot about a ton of different things. What can PT do for me beyond what I've told you today? There's so much, okay? Pelvic floor lengthening, like we talked about with the fist, pelvic floor strengthening if those muscles are weak. We can do bladder retraining and voiding coordination, so helping our bladder relearn when it's okay to release and when we should contract. Bowel dysfunction treatment, managing constipation, managing diarrhea, leakage, bowel movement positioning, constipation management, if you're having pain with bowel movements. Sometimes people say they have spasms when they have a bowel movement. Pain management, big one. Desensitization training and downregulation work. Sensory integration. Dietary modifications. Fluid modifications. Sexual functioning, if you're having pain with sex, if you're having a difficult time finding comfortable positions with that. Lifestyle modifications, breathing mechanics, lifting mechanics, postural training, pregnancy and birth preparation is a big one, and positioning to make your body comfortable. Male pelvic floor dysfunctions, okay? I work a lot with male clients who have prostate dysfunction, prostate cancer, leakage related to a lot of that stuff. Very common problem as well. Transgender affirming procedures and care. So helping people adjust to that new normal. Return to work and recreational activities, helping people get back to running, pickleball, cross-country skiing, all of those stuff. So you might avoid some of those activities if you're having leakage all the time. So helping you comfortably transition back to those activities you love. So most of these problems we've talked about, unfortunately, they can take a long time to get better, okay? They take generally weeks to months of some consistent hard work to change and make improvements. Sometimes these little tweaks, tips, and tricks that we implement can really help and make things better. too at the same time. So hopefully you've learned a few takeaway points that you can get yourself started. But if you are struggling to manage any of these problems, please do not hesitate to reach out. I work at North Shore Health. We work with everyone on a one-to-one basis. So you are getting individualized care. We can dive into what your specific issues are and your concerns. Then my information and my email is at the bottom there, and then I have business cards in the back of the room if you need one of those. Questions? I know that's a whirlwind. Oh, and I'm also next month, I'm talking about urinary problems much, much more in depth. So.
Great.
Chicken. Again, everything is going to be different, but when I talk about supplements, I usually mean like if you're adding like a Benefiber, even like a Miralax, some of those like prepackaged powders.
Psyllium also?
Psyllium can be, yeah, psyllium, psyllium is tricky because psyllium can be sold as, I think Benefiber is psyllium. No, it might be inulin.
Metamucil has the.
Metamucil is, yep, so like a Metamucil, so it can be packaged as prepackaged powder. You can also buy psyllium husk as a separate thing. If you're looking for a little bit more of a natural fiber supplement of sorts, I usually like to recommend psyllium husks or flaxseed. Okay, sprinkle in some oatmeal or yogurt. That's a great way to add fiber easily. But yeah, there are a million supplements on the market. And unfortunately, the supplements are not necessarily regulated by the FDA, so it can be very tricky. Yeah, did that answer that?
That helped, thank you.
Okay. Yeah.
Regarding prolapse, a doctor would observe that in a annual exam, yes?
Yeah, if they do an internal
Yeah.
exam as part of
Like a
your
pap smear, right? They're
Yeah.
gonna be looking at the same.
Yeah, they should. If for some reason you're at the age where they're like, we don't need to do a pap smear, you can always ask for an exam to see if you have prolapse.
A certain age.
Yeah, you do. Usually, a lot of times they, pap smears are not inherently comfortable. So if you don't need one, they generally don't do one. But if you are having some of these symptoms, never hurts to ask and say like, hey, is this going on here? Like, is this something that I should be concerned about and try to start working on?
So we have a question in chat about, does insurance usually cover PT and or surgery or any of the pieces along this?
It depends on your insurance. Generally, insurance is a hot topic these days, I would say. But yes, generally, pelvic floor physical therapy for any of the conditions we've talked about today is covered by insurance. However, I always give the caveat now, you should call your insurance and verify that it is generally up to a certain number of visits, as long as we deem it medically necessary, which is fairly easy to do, it's usually covered. If you are Medicare, a doctor's order to see a physical therapist for these conditions is great. If you are not Medicare age, Minnesota is a direct access state, and you can actually come to physical therapy as a first line treatment and not necessarily need a physician's orders. And that's in Minnesota, so cannot speak for the country, but in Minnesota, we have direct access.
Can you repeat how to correctly perform a pelvic contraction?
Yeah, so to do a pelvic floor contraction, what you are going to do is first just relax all your muscles, concentrate on your pelvic floor. You are going to gently draw your pelvic floor up and in, imagining that you are picking up a blueberry with your vagina. Or for males, contract your penis and try to pull it up and in. You might find that your belly contracts and pulls in slightly. That's normal. You should not feel your butt clench. You should not feel your shoulders and your chest clench, okay? If you try to do a Kegel and you're like, wrong, isolate, Okay, less is more sometimes. I say, if you're doing a pelvic floor contraction, no one else should know you're doing it. Okay, if you are sitting in your seat and you find yourself rising up a little bit high, okay, okay, that is a key sign that you can do less. Okay, isolate the pelvic floor muscles a little bit more. Focus on gently drawing up and in of just those bottom tissues, not the entire body per se. This is my prolapse chicken. So if you are breathing incorrectly,
And maybe I missed it, but do you have this ball that
yeah,
extends?
I totally forgot about it. It was behind my laptop. So this is my breathing ball. So this is a great trick we use to learn how to breathe and do a pelvic floor contraction appropriately. So, great example is that sit to stand that we practice. Okay, so if you are just holding your breath, okay, boom is going to put pressure down on that pelvic floor. Okay, as you breathe out, you should feel your abdominals contract slightly. You should feel your pelvic floor contract slightly. Your abdominal muscles play a part in breath exhalation. Okay, so that is naturally going to be a part of that. Now, when you sit down, that was when you would breathe in slightly. So if you're confused about what your pelvic floor should be doing, I always say recognize what your abdominals are doing. Okay, if you breathe in, your belly gets bigger. Okay, meaning your pelvic floor should be lengthening, getting bigger as well. If you are breathing out and your abdominals are relaxing and coming in, your pelvic floor should also be coming in. So your trunk functions like the breathing ball. Okay, breathe in, everything opens up, breathe out, contract, everything comes in nice and tight. Okay, as you're going through movements in your day-to-day life, you should not be here. Okay, here is here, right? Throughout the day, we should be fluctuating in the middle ground here. Walking around, lifting, we're rocking here. When we're relaxed, we're here. When we're bracing as hard as we can, we're here. But for the most part, we're in the middle. Great questions, guys. Anything else, Kelsey?
No, sorry, we were
You're
having
good.
people that are asking questions online.
Oh,
I think you're good with everything. I've just been processing and saying thank you. That's
For
what
sure.
everybody's been.
For sure.
processing.
thank you everyone for coming.
Well, I encourage you to hang out a little longer if you have like a last minute question you want to ask one-on-one, or if you have some conversation you want to have. We're so glad you came today and hope to see you at the next session. And then again, this was recorded, so if you know from your life and missed it, and would be best to hear it. Recommend them to go to our website and I can check it out there.
When is the next?
Oh, great question.
I'll pull it up for you in a minute.
Monday in February, same time.
Any other questions that anybody's had of
Feel free to come check out any of the models if you have specific questions. I'll be happy to answer those.
Well, man has like an overactive bladder. So you sit down, stand,
Yeah,
it's like that. Yeah. You know, what usually causes that?
a lot of the same things we've talked about today. Weak pelvic floor muscles. First thing I'd like to figure out if it is a male client, I'd like to investigate whether there's any prostate involvement. A lot of times that can be one of the first signs of something.
Had prostate surgery to
Yeah.
like a TUR.
Yes, a TURP procedure. Yeah, so a TURP procedure is a transurethral resection of the prostate. A lot of times that's if people are having urinary retention problems. So we're talking about male pelvic floor here. Or prostatectomy. So that is a full removal of the prostate. There is actually some muscle lining surrounding the urethra in the male pelvic floor. And so when there is a prostate surgery, some of that muscle is removed or damaged or taken out. Sometimes the internal urethral sphincter can actually be damaged during surgery, or if the nerves are impacted. So a lot of times male clients don't necessarily have pelvic floor issues until after a procedure like that because some of their muscle was just taken out all of a sudden. Okay. And so they went from like a full muscle volume and now they're down at like a 2/3 volume. So we have to work on strengthening up that other side. Now you can also get male pelvic floor problems without any of those things going on. That is generally a lot of the other things we've talked about, breathing dysfunctions, not managing your pressures in your stomach well. So holding your breath every time you're doing something. Weakness. As we get older, we get weaker unless you're actively trying to stay strong and prevent that. So it could be a pelvic floor muscle weakness, a lot of different things, but